Hello, I'm Professor Peraza, and today's lecture video covers the digestive system and common digestive conditions. These are the specific learning objectives for this module. This module also meets the following course learning objective. For this lecture, these two free textbooks are your primary reference materials. More information, including page numbers for readings, can be found in the Canvas course space for this module. Before we get into our lecture, I want you to think of one topic area or question that you're hoping to have answered or hope to learn more about in this lecture. Before we review the digestive system, we need to first review the different levels of organization in the body. Cells are the most basic building blocks of life. All living things or organisms are composed of cells. A tissue is a group of many similar cells that share a common structure and work together to perform a specific function. There are four basic types of human tissues: connective tissue, which maintains the form of the body and provides internal support; epithelial tissue, which covers the surface of the body and lines and protects organs; muscle, which contracts for movement and support; and nerve, which responds and reacts to signals in the environment by transmitting nerve impulses. An organ is a group of similar tissues working together to perform a specific function. Examples include the liver, kidneys, and heart. Groups of organs are organized into organ systems that support a specific function. For example, the digestive system breaks down food and absorbs its nutrients. An organism is the complete living system capable of conducting all of life's biological processes. Let's review the overall flow with the digestive system. The digestive system is composed of hollow-shaped tube organs, including the mouth, pharynx, esophagus, stomach, small intestine, large intestine, colon, and rectum. This continuous tube is called the digestive tract, gastrointestinal, GI tract, or the alimentary canal. It is lined with mucosal tissue that secretes digestive juices, which aid in the breakdown of food, and mucus, which facilitates the movement of food through the tract. Let's review the process of digestion, which is necessary for us to use the nutrients from foods. There are four main steps in the digestion process: ingestion, digestion, absorption, and excretion. The process of digestion begins even before you put food into your mouth. When you feel hungry, your body sends a message to your brain that it's time to eat. Sights and smells influence your body's preparation for food, with your brain telling your mouth to get ready, leading to salivation. Ingestion refers to food entering the GI tract through the mouth. The second step, digestion, occurs in the mouth when food is chewed, which allows for the food to be broken into smaller pieces, and also for this food to be mixed with saliva, which contains enzymes that start the breakdown of carbohydrates and lipids. Food in the mouth is called a bolus. Mechanical digestion is the physical process of making food particles smaller. This includes mixing, shredding, and moving food around. The chewing process is called mastication. Chemical digestion includes digestive secretions that contain enzymes which start the breakdown of macronutrients into building blocks. Enzymes are chemicals that speed up chemical reactions in the body. Absorption primarily takes place within the small intestine and is the reason we can take nutrients and utilize them. Lastly, in excretion, any undigested materials are eliminated from the body as feces. Let's start at the top and review the GI tract more in detail. First up is the mouth. In the mouth, teeth will grind and crush food into smaller particles. As you chew, saliva mixes with the food and forms a bolus. Salivary glands are accessory organs that produce saliva. Saliva is composed of water, enzymes, and other chemicals. Salivary amylase, a digestive enzyme, begins the breakdown of starch. Lingual lipase, another digestive enzyme, starts the breakdown of triglycerides, the main form of fat in food. Lysosome, also in saliva, kills bacteria. Mucus helps to lubricate and hold the bolus together. As you prepare to swallow, your tongue and pharyngeal muscles aid in propelling the bolus into your esophagus. The pharynx, also known as the throat, is divided into three parts: nasal, oral, and laryngeal. The nasal pharynx is located behind the posterior nasal apertures. The nasal pharynx is only related to the respiratory tract as air passes through it from the nasal cavities. The oral pharynx is located behind the opening of the oral cavity. It is a continuation of the oral cavity and functions to pass the bolus toward the laryngeal pharynx below. The laryngeal pharynx is located behind the inlet opening of the larynx. When the bolus of food moves from your mouth, muscles of the soft palate contract to close so food does not enter the nasal cavity. At the same time, the epiglottis, cartilage at the upper part of your larynx, closes over the laryngeal inlet, which prevents food from entering your airways. The laryngeal pharynx then receives the bolus from the oral pharynx and passes it into the esophagus for digestion. The esophagus is a muscular tube that transports food from your mouth to your stomach. The bolus is pushed through your esophagus via peristalsis waves of contraction. Peristalsis is a one-way movement with waves of contraction and relaxation of the smooth muscles of the GI tract. Peristaltic contractions in the esophagus propel the food bolus down to the stomach. The bolus reaches the stomach from the wave of peristaltic contractions. At the bottom of the esophagus is the lower esophageal sphincter located between the esophagus and the stomach. The sphincter relaxes so the bolus can enter your stomach. If the sphincter malfunctions, heartburn can occur. This is a condition we will cover in this lecture. There are other sphincters in the body. These are ring-like muscles. They work like valves to control the flow of contents. The sphincters also allow for thorough mixing to occur, preventing contents from moving too quickly, and also help to propel food forward. The stomach is about the size of a fist when empty, but can stretch to hold as much as 4 liters of food and fluid. The stomach serves as a temporary holding tank. You can ingest a meal far more quickly than it can be digested and absorbed by the small intestine. The time food will stay in the stomach will vary based on the macronutrient composition. A meal with more fat or protein will take longer to break down than one with carbohydrates. It usually takes a few hours after a meal to empty the stomach contents completely into the small intestine. Peristaltic waves also occur in the stomach to mash and churn food into what is now called chyme. Chyme is a semi-liquid and contains the partially digested food along with gastric juices. Cells lining the stomach produce gastric juice, which contains HCl, hydrochloric acid, which kills bacteria on food and denatures the food structure. Pepsin, an enzyme that breaks protein down, and lipase, which breaks down fats, pepsinogen, and then also gastrin. Gastric juices are secreted when we smell, see, taste, or even think about food. The mucus cells also secrete mucus, which helps to lubricate and protect the stomach from being digested by HCl and pepsin. Production of this mucus is dependent upon prostaglandins. The use of NSAIDs, non-steroidal anti-inflammatory drugs, can inhibit the production of mucus, which can lead to potential damage to the stomach wall by stomach acids. Intrinsic factor is also secreted by the stomach lining. This is a glycoprotein required for the absorption of vitamin B12. Some individuals, especially the elderly, do not make enough intrinsic factor, which could lead to pernicious anemia, a type of B12 deficiency. Chyme is slowly released into the small intestine via the pyloric sphincter. Only small amounts are passed at a time to protect the delicate lining of the small intestine from the acidic chyme. Neutralizing bicarbonate is added to the chyme as it enters the small intestine. The primary site for digestion and absorption is in the small intestine. There are 3 parts of the small intestine: duodenum, jejunum, and ileum. When chyme enters the duodenum, the first segment of the small intestine, the pancreas and gallbladder release juices that aid in digestion. Both peristalsis and segmentation occur in the small intestine. Peristalsis is important in the small intestine to propel chyme in a generally forward direction. Segmentation is a mixing motion back and forth that helps to break food apart and allow for digestive juices to act on the chyme. Segmentation also allows for enhanced nutrient absorption. Most food is broken down to its simple units within the first 25 centimeters of the small intestine. Instead of proteins, carbohydrates, and lipids, the chyme now consists of amino acids, monosaccharides, and emulsified components of triglycerides. Nutrient absorption, the third step of digestion, takes place mainly in the jejunum and ileum of the small intestine, which may be more than 5 meters in length. The small intestine is structured to maximize nutrient absorption. There are multiple folds within the small intestine, along with villi and microvilli. Villi are tiny finger-like projections that protrude from the epithelial lining of the small intestine wall. These villi are covered with absorptive cells composed of smaller projections called microvilli. These microvilli are collectively known as the brush border. Their appearance is similar to bristles on a brush. The microvilli increase the surface area in the small intestine and allow for nutrient absorption. The digested nutrients pass through the absorptive cells of the intestine via diffusion or special transport proteins. The accessory organs are not actually part of the GI tract, but are critical to the function. The liver produces bile, which aids in fat digestion and absorption, and this is concentrated and stored in the gallbladder. Bile helps to emulsify fats, or basically break large droplets into smaller ones and allow them to mix with digestive juices. Bile passes through a duct that joins the pancreatic ducts and is released into the duodenum. Bile is reabsorbed during a meal, and any not absorbed is excreted in the feces, which also means some cholesterol is removed. The pancreas produces and secretes pancreatic juices, which includes water, bicarbonate, which neutralizes the acidic chyme, and enzymes that break down macronutrients. Pancreatic amylase digests starch, pancreatic lipase digests fats, and proteases digest proteins. The hepatopancreatic sphincter, or sphincter of Oddi, is a combination of the common bile duct and pancreatic duct, and this delivers secretions to the small intestine. Once nutrients are absorbed in the small intestine, water-soluble nutrients, glucose, amino acids, and water-soluble vitamins and minerals are absorbed into the blood and directly to the liver via a major blood vessel called the portal vein. Lipids are absorbed into the lymphatic system, which also contains immune system components, such as white blood cells and a liquid called lymph. The lymphatic system slowly moves its contents through the lymphatic vessels and empties into blood vessels in the upper chest area. Now, the absorbed lipid-soluble components are in the blood, where they can be distributed throughout the body and utilized by cells. The lymphatic system is a system of tissues, vessels, and organs that work to move lymph back into your bloodstream. This system provides an alternative route to the bloodstream for those larger molecules. The liver helps regulate distribution of the nutrients throughout the body to supply the needs of all the cells. Once the liver's primary functions, and one of the liver's primary functions is to regulate metabolic homeostasis, which is achieved when the nutrients consumed match the needs of the body. The liver is capable of exporting nutrients for energy production to other tissues. Levels of nutrients and hormones in the blood signal the liver to store or release glucose. Other signals lead to the storage of lipids in adipose tissue or release of stored lipids for body cells to use as fuel to produce energy. Food moves from the small intestine through the ileocecal valve and into the large intestine. At this point, mostly what is left is indigestible fiber, water, and some minerals. The large intestine is composed of 4 parts. It includes the cecum and ascending colon, transverse colon, descending colon, and sigmoid colon. The large intestine has 3 primary functions: absorbing water and electrolytes, producing and absorbing vitamins, forming and propelling feces toward the rectum for elimination. By the time indigestible materials have reached the colon, most nutrients and up to 90% of the water has been absorbed by the small intestine. The role of the ascending colon is to absorb the remaining water and other key nutrients from the indigestible material, solidifying it to form stool. Sodium is actively absorbed in the colon by sodium channels. Potassium is either absorbed or secreted depending on the concentration in the lumen. The colon also plays a role in providing required vitamins through an environment that is conducive for bacterial cultivation. The colon houses trillions of bacteria that protect our gut and produce vitamins. The bacteria in the colon produce substantial amounts of vitamins by fermentation. Vitamin K and B vitamins, including biotin, are produced by the colonic bacteria. These vitamins are then absorbed into the blood. When dietary intake of these vitamins is low in an individual, the colon plays a significant role in minimizing vitamin disparity. Feces is composed of any undigested food residues, unabsorbed digestive substances, bacteria, and old cells from the lining of the GI tract. The descending colon stores feces that will eventually be emptied into the rectum. The sigmoid colon contracts to increase the pressure inside the colon, causing the stool to move into the rectum. The rectum holds the feces, awaiting elimination by defecation. Let's talk more about the health of your gut microbiota and microbiome. Microbiota describes the living microorganisms found in a defined environment, such as oral and gut microbiota. Microbiome refers to the collection of genomes from all the microorganisms in the environment, which includes not only the community of the microorganisms, but also the microbial structural elements, metabolites, and the environmental conditions. Gut microbiota is considered the most significant one in maintaining our health. Gut microbiota refers to the trillions of microorganisms, including bacteria, viruses, fungi, and archaea that live in your digestive tract, gastrointestinal tract. The gut bacteria serve several functions, such as fermentation of food, protection against pathogens, and stimulating immune response and vitamin production. Microbiota may affect biological processes via several mechanisms. For energy and nutrient extraction from food, microbiota play crucial roles due to the versatile metabolic genes, which provide independent, unique enzymes and biochemical pathways. The biosynthesis of bioactive molecules, such as vitamins, amino acids, and lipids, are also highly dependent on the gut microbiota. The human microbiota not only protects the host from external pathogens by producing antimicrobial substances, but also serves as a significant component in the development of intestinal mucosa and immune system. In healthy conditions, the gut microbiota exhibits stability, resilience, and symbiotic interaction with the host. A healthy microbiota community often demonstrates high taxonomic diversity, high microbial gene richness, and stable core microbiota. Gut microbiota may vary due to age and environmental factors, for example, medication usage. Gut microbiota vary in different anatomical parts of the GI tract. Evidence has confirmed that microbiota is associated with the development of cardiovascular diseases, cancer, respiratory diseases, diabetes, IBD, brain disorders, chronic kidney diseases, and liver diseases. Gut microbiota is involved in the metabolism of choline and carnitine, which eventually produce trimethylamine N oxide, or TMO. TMAO has been suggested to not only regulate cholesterol balance and bile acid levels, but is also associated with early atherosclerosis and high long-term mortality risk of CVDs. Gut microbiota is able to metabolize polysaccharides and proteins into short-chain fatty acids, another class of metabolites that is linked to cardiovascular diseases. Short-chain fatty acids, particularly propionates and butyrates, were shown to protect the host from hypertensive cardiovascular damage. The butyrate has been shown to modulate blood pressure by inhibiting expression of renal prorenin receptors and renin in animal models. Recent studies have shown that microbiota play an important role in carcinogenesis, mainly through influencing the host cell proliferation and death, altering immune system activity, and affecting host metabolism. Studies have shown that dysbiosis of gut microbiota can trigger inflammation and immune response that are indirectly related to carcinogenesis. Microbial products may induce epithelial barrier deterioration, which trigger tumor-elicited inflammation and drive initiation and progression of colorectal cancer. Gut microbiota has been linked to type 2 diabetes. Numerous studies have confirmed that the composition of gut microbiota is altered in type 2 diabetes patients. Studies have shown that gut microbiota are highly associated with the development of irritable bowel diseases. We will cover this a bit later. Microbiota dysbiosis is linked through IBD through its impact on inflammation as well as the intestinal barrier. Preclinical studies have established that gut microbiota affects cognitive performance, repetitive behaviors, and social interactions in different animal models. Both major brain disorders, depression and anxiety, are indicated to be influenced by stress-regulated HPA axis pathway, which is believed to be strongly modulated by gut microbiota composition. Accumulating body of evidence from various studies are emphasizing the importance of gut microbiota in the progression of various neurological diseases, such as Alzheimer's disease, CVS, Parkinson's disease, and schizophrenia. It has been evident that gut microbiomes are involved with the regulation of brain activity via the effect on the host's innate immunity. There are many factors that influence your microbiome. Everyone has a unique network of microbiota. Infants are exposed to microorganisms via the birth canal and also with the mother's breast milk. Genetics and lifestyle also shape the bacteria that live in your gut. Diet plays a major role in shaping your microbiome. Plant-based foods, specifically fiber, has been shown to increase microbial diversity. Any interruption in the balance of microbiota can lead to dysbiosis. The most typical features of dysbiosis are decrease in the diversity of the microbiota, a loss of beneficial microbiota, or an overgrowth of harmful microbiota. Dysbiosis can be caused by host-specific factors such as genetic background, health status, inflammation, infections, and lifestyle habits, or more importantly, environmental factors such as diet, high sugar, low fiber, zymbiotics, so antibiotics, drugs, food additives, and hygiene. Many infectious diseases, even if they're not gastrointestinal, trigger dysbiosis of the gut microbiota. We're going to talk about probiotics and prebiotics, which are a big topic when discussing the gut microbiota. First are probiotics. Probiotics are live microorganisms that are intended to have health benefits when consumed or applied to the body. Many of the microorganisms in probiotic products are the same or similar to microorganisms that naturally live in our bodies. The most common bacteria are those that belong to the lactobacillus and bifidobacterium groups. Probiotics can be found in yogurt and other fermented foods along with their dietary supplements. Specific examples include miso, kefir, tempeh, kimchi, and kombucha. If the food is pasteurized, baked, or filtered, it can kill or remove live cultures. Probiotics are measured by what's called CFU, or colony-forming units. This is the number of bacteria able to divide. Having a higher CFU does not necessarily mean more health benefits. Much of the research has been centered around 1 to 10 billion and on specific strains. There's still much research to be done here, as it isn't clear in many instances which are the best probiotics and which are not. Probiotics can be beneficial by helping your body maintain a healthy community of microorganisms, or helping your body's community of microorganisms return to a healthy condition after being disturbed, producing substances that have desirable effects, influencing your body's immune response. Probiotics have shown promise for a variety of health purposes, including prevention of antibiotic-associated diarrhea, including diarrhea caused by C. diff, prevention of necrotizing enterocolitis and sepsis in premature infants, treatment of infant colic, treatment of periodontal disease, and induction or maintenance of remission in ulcerative colitis. Prebiotics are non-digestible food components that are selectively stimulate the growth or activity of desirable microorganisms. They can feed the intestinal microbiota, and their degradation products are short-chain fatty acids that are released into blood circulation, affecting not only the GI tract, but also other distant organs. Food sources of prebiotics include inulin, like chicory, wheat, onion, garlic, and bananas, and resistant starch, like seeds, legumes, potatoes, and unripe bananas. Not all prebiotics are carbohydrates, and other sources include microalgae, human milk, tomatoes, and soybeans. Increasing evidence suggests that diets rich in prebiotics are linked to improved immune functions. Consuming prebiotics can improve immunity functions by increasing the population of protective microorganisms. Prebiotic oligosaccharides have been used to alleviate atopic dermatitis and allergy symptoms in children under 2 years old. Prebiotics and probiotics enhance immune function by altering gut microbiota composition, resulting in elevated amounts of beneficial bacteria, such as bifidobacteria. Symbiotics consist of prebiotics and probiotics. They synergistically promote the survival and proliferation of beneficial gut bacteria, resulting in enhanced gastrointestinal health and general immunity. The term postbiotic refers to the process of preparing inert bacteria and/or their components in a way that benefit the host's health. Postbiotics are bioactive substances that are created during the fermentation of probiotic bacteria. These molecules have been associated with several beneficial health effects. Postbiotics and symbiotics demonstrate anti-inflammatory effects, aiding in managing illnesses such as colitis and alleviating gastrointestinal discomfort. Furthermore, postbiotics and symbiotics have antioxidant activity, mitigating oxidative stress and promoting general health, especially in diabetes and metabolic disorders. Let's review some digestive issues that can arise. Heartburn is a burning feeling in your chest or throat. Despite its name, heartburn actually has nothing to do with your heart. There are several conditions that cause heartburn, but most often it's caused by acid reflux or GERD. Gastroesophageal reflux, GER, happens when your stomach contents back up into your esophagus. Many people have reflux once in a while, and reflux often happens without causing symptoms. In some cases, reflux may cause heartburn, also called acid indigestion. Having reflux once in a while is common. Your lower esophageal sphincter and diaphragm most often prevent reflux, which is when stomach contents come back up through your esophagus. Gastroesophageal reflux disease, GERD, is a more severe and long-lasting condition in which gastroesophageal reflux causes repeated symptoms that are bothersome or leads to complications over time. GERD may develop if your lower esophageal sphincter becomes weak or relaxes when it shouldn't. Anyone can develop GERD, but it is more common for those who have obesity, are pregnant, smoke, have a hiatal hernia, or take certain medications, NSAIDs, calcium channel blockers, and sedatives. Without treatment, GERD can sometimes cause serious complications over time, such as esophagitis, esophageal stricture, and Barrett's esophagus, as well as complications outside of the esophagus. Esophagitis is inflammation in the esophagus. Esophagitis may cause ulcers and bleeding in the lining of the esophagus. An esophageal stricture happens when your esophagus becomes too narrow. Esophageal strictures can lead to problems with swallowing. GERD can sometimes lead to Barrett's esophagus, a condition in which tissue that is similar to the lining of your intestine replaces the tissue lining your esophagus. This can lead to cancer. Some of the symptoms for both conditions include heartburn, painful burning feeling in the middle of your chest, behind your breastbone, rising from the lower tip of the breastbone towards your throat, regurgitation or stomach contents coming back up through your esophagus and into your throat or mouth, which may cause you to taste food or stomach acid. Some people might also experience nausea, chest pain, or problems swallowing. Doctors diagnose reflux and GERD by reviewing symptoms and medical history. They may order an upper GI endoscopy to check for complications of GERD. Let's look at lifestyle management for reflux and GERD. Consuming smaller, more frequent meals versus large ones, wearing loose-fitting clothing, avoiding eating 3 hours before bed, staying upright 3 hours after eating, quitting smoking, and raising the head of the bed by 6 to 8 inches, which can be accomplished with foam blocks. Pillows not recommended. As for dietary management, some people who have GERD find that certain foods or drinks trigger symptoms or make symptoms worse. Foods and drinks that have been commonly linked to GERD symptoms include acidic foods such as citrus fruits and tomatoes, alcoholic drinks, chocolate, coffee, and other sources of caffeine, high-fat foods, mint and spicy foods. Certain medications may also be recommended for reflux, including antacids for mild heartburn, H2 blockers to reduce stomach acid, and PPIs, which also reduce stomach acid and can heal the esophageal lining better than H2 blockers. Peptic ulcer disease, PUD, is characterized by discontinuation in the inner lining of the GI tract because of gastric acid secretion or pepsin. It usually occurs in the stomach and proximal duodenum. It may involve the lower esophagus, distal duodenum, or jejunum. When the mucous coating of the GI tract is damaged, this can lead to the tissue exposed to pepsin and HCl, which further erodes the tissue. It can lead to pain and bleeding. Common signs and symptoms include epigastric abdominal pain, bloating, abdominal fullness, nausea and vomiting, weight loss, weight gain. Common causes include H. pylori infection, NSAIDs, and medication. H. pylori is found within the gastric epithelial cells. This bacterium is responsible for 90% of duodenal ulcers and 70 to 90% of gastric ulcers. H. pylori infection is more prevalent among those with lower socioeconomic status and is commonly acquired during childhood. Nonsteroidal anti-inflammatory drug use is the second most common cause of PUD after H. pylori infection. The secretion of prostaglandin normally protects the gastric mucosis. The NSAIDs block prostaglandin synthesis. Apart from NSAIDs, corticosteroids, biphosphates, potassium chloride have been implicated in the etiology of peptic ulcer disease. Smoking also appears to play a role in duodenal ulcers, but the correlation is not linear. Alcohol can irritate the gastric mucosa and induce acidity. It was previously believed that stress led to an ulcer. However, stress is not the root cause of ulcers, so treating with a bland diet or stress reduction will not cure or prevent the ulcer from forming. Treatment for an ulcer will depend on the root cause. Ulcers caused by H. pylori infection are treated with antibiotics to kill the bacteria, with the addition of an acid-suppressing medication to allow tissue to heal. To treat an ulcer caused by NSAIDs, doctors recommend stopping or reducing the use of NSAIDs. They may prescribe an acid-reducing medication to allow the tissue to heal. Nutrition-wise, addressing deficiencies due to inadequate intake would be critical. Metabolic dysfunction-associated steatotic liver disease was previously named non-alcoholic fatty liver disease. In 2020, Eslam et al. Proposed the new term, metabolic dysfunction-associated fatty liver disease, which could be diagnosed in adults with hepatic steatosis detected by imaging techniques, blood biomarkers, or liver histology when overweight or obese in the presence of type 2 diabetes or at least 2 metabolic risk abnormalities. In June 2023, a multi-society Delphi consensus statement on a new fatty liver disease nomenclature was published, introducing the term metabolic dysfunction-associated steatotic liver disease and effectively retiring the term non-alcoholic fatty liver disease. This disease involves accumulation of fat in the liver and may progress to liver inflammation and scarring. It is the most common chronic liver disease worldwide. The main risk factors are obesity and type 2 diabetes. Other risk factors include prediabetes, elevated blood glucose levels without a diagnosis of diabetes, older age, male sex, certain genetic variants, and postmenopausal status. Behavioral risk factors include having a sedentary lifestyle, smoking, consuming alcohol, drinking sugar-sweetened beverages, and eating diets high in saturated fats, sugars, and processed foods. Although most people have no symptoms, some people feel tired or have pain or discomfort in the upper right side of their abdomen. People often have high blood lipid levels, especially triglycerides, low high-density lipoprotein, HDL cholesterol, elevated blood glucose, and high blood pressure. This condition is diagnosed by detection of fat accumulation in the liver, typically with ultrasound imaging, along with at least one of the following 5 risk factors: excess abdominal fat or obesity, prediabetes or type 2 diabetes, high blood pressure, high blood triglycerides, and low HDL cholesterol in individuals without substantial alcohol consumption and no other known causes of fatty liver. Behavioral modifications are first-line treatment. Nutrition plans should be tailored to the individual's social, work, cultural, and financial context and provided in a practical, implementable format. Evidence suggests that no ideal calorie percentage from carbohydrates, proteins, and fats can be broadly recommended for all people with prediabetes or diabetes. However, nutrition plans high in saturated fat and sugar, from sucrose and or high fructose corn syrup, are associated with postprandial hypertriglyceridemia, insulin resistance, and higher risk of liver disease, with fibrosis progression in high-risk individuals. In macronutrient distribution, avoidance of ultra-processed foods and reduction in saturated fat and simple sugars and fructose consumption to be emphasized, as should an eating pattern enriched with high fiber and unsaturated fats. A culturally appropriate Mediterranean eating pattern, rich in fruits, vegetables, whole grains, and heart-healthy fats, is preferred due to the best long-term data on beneficial cardiometabolic risk factor reduction and mortality benefit. Structured exercise has been shown to decrease insulin resistance and steatosis. Minimizing sedentary time and engaging in brief sessions, about 10 minutes of simple activities such as walking, with the goal of meeting activity guidelines, should be encouraged. Resistance training may prevent sarcopenia and functional decline. The FDA has approved 2 medications for adults with this condition who have moderate to advanced liver fibrosis without cirrhosis. Bariatric surgery may also be considered for people, especially if behavioral modifications and medications have not produced adequate weight loss. Next up are gallstones. Gallstones are hard, pebble-like pieces of material, usually made of cholesterol or bilirubin, that form in the gallbladder. Gallstones can range in size from a grain of sand to a golf ball. The gallbladder can make one large gallstone, hundreds of tiny stones, or both small and large stones. When gallstones block the bile ducts of the biliary tract, the gallstones can cause sudden pain in the upper right abdomen. This pain is called a gallbladder attack or biliary colic. Gallstones are very common. Being overweight or having obesity can increase the likelihood of gallstones, especially for women. Researchers have found that people who have obesity may have higher levels of cholesterol in their bile, which can cause gallstones. Losing weight very quickly may raise the chances of forming gallstones. When you don't eat for a long period of time or you lose weight quickly, the liver releases extra cholesterol into the bile. Fast weight loss can also prevent the gallbladder from emptying properly. Complications of gallstones can include inflammation of the gallbladder, severe damage or infection of the gallbladder, bile ducts, or liver, gallstone pancreatitis, which is inflammation of the pancreas due to a gallstone blockage. Many people do not have symptoms of gallstones until they have complications. If left untreated, gallstones can be deadly. Treatment for gallstones usually involves gallstone surgery. Bile is still produced even after gallbladder is removed. The liver will continuously produce bile, but it will be released directly into the small intestine instead of being stored and released in a concentrated form. After surgery, the body's ability to digest fats is somewhat reduced, leading to some mild discomfort or alterations in bowel patterns, especially after consuming high-fat meals. Fat can still be consumed, though some individuals may need to have smaller meals and avoid very high-fat meals. A specific low-fat diet is not often needed. Prevention of gallstones includes maintaining a healthy weight, avoiding rapid weight loss, eating more fiber and healthy fats, reducing refined carbohydrates and added sugars, and exercising. Let's review diarrhea versus constipation, which are both common and can be connected to some of the conditions we will explore next. Both diarrhea and constipation can occur if the normal function and rhythm of the GI tract is disrupted. If waste matter moves too quickly through the large intestine, not enough water is absorbed, resulting in loose, watery stools, characteristic of diarrhea. Diarrhea is passing loose, watery stools 3 or more times a day. Diarrhea may be acute, persistent, or chronic. Diarrhea can occur due to infections, food allergies, intolerances, medications like antibiotics, sugar alcohol consumption, or digestive tract issues. Diarrhea can be a symptom of food poisoning. Medicines such as antibiotics, antacids containing magnesium, and medicines commonly used to treat cancer may cause acute diarrhea. Some infections may also cause ongoing diarrhea. Digestive tract problems that can cause chronic diarrhea include celiac disease, Crohn's disease, and ulcerative colitis. We will cover these and food allergies and intolerances later. Diarrhea can lead to dehydration and malabsorption. Although rare, becoming dehydrated can lead to serious health problems such as organ damage, shock, coma, or even death. Chronic diarrhea can cause malabsorption, leading to malnourishment. Certain conditions that cause chronic diarrhea, such as infections, food allergies, and intolerances, and certain digestive tract problems may also cause malabsorption. Treatment involves replacing lost fluids and electrolytes with water and liquids. Determining the root cause would be important. However, there are some things to avoid with diarrhea that can make it worse, such as alcohol, caffeine, high simple sugars, so juice, candy, etc., sugar alcohols, high-fat foods, and milk, lactose. Constipation is a condition where an individual has infrequent bowel movements, less than 3 times a week, stool that is hard, dry, or lumpy, stools that are difficult or painful to pass, and a feeling that not all stool has passed. Constipation is not a disease, but a symptom of another medical problem. Constipation can occur due to pregnancy or just after delivery, in older adults, in individuals who eat minimal amounts of fiber, dehydration due to medications, or different GI disorders. Medications like antacids and anticonvulsants can make constipation worse, along with diuretics, iron supplements, and certain depression medications. Delayed emptying of the colon from pelvic floor disorders, especially in women, and colon surgery can also contribute. Complications include bleeding and unintentional weight loss. Treatment includes many components and, again, will also depend on the root cause. Increasing dietary fiber and fluids would be key to soften stool and make it easier to pass. Physical activity can stimulate the bowels. Adjusting medications and supplements under the guidance of your doctor. Laxatives should only be used for a short time and if the constipation is severe and other options have not worked. Other ways to help with constipation can be relaxation exercises. Irritable bowel syndrome, IBS, is a type of functional GI disorder, meaning that it's caused by a disruption in the signals between the brain and the gut. 3 types of IBS are based on different patterns of changes in bowel movements or abnormal bowel movements. IBS with constipation, IBS-C, IBS with diarrhea, IBS-D, IBS with mixed bowel habits, IBS-M. The most common symptoms are abdominal pain, often due to bowel movements and bowel movement changes. Additional symptoms include bloating. Doctors aren't sure what causes IBS. Experts think that a combination of problems may lead to IBS. In some people with IBS, food may move too slowly or too quickly through the digestive tract, causing changes in bowel movements. IBS can co-occur with other conditions like fibromyalgia, chronic fatigue syndrome, GERD, anxiety, and depression. Bacterial infections, food intolerances, and genes may play a role. In most cases, doctors don't use tests to diagnose IBS. Typically, a doctor reviews symptoms and medical family history. Often, tests are done to rule out other conditions. Treatment depends on the type of IBS. We discussed ways to manage diarrhea and constipation previously. Some people find that eating more fiber-rich foods and increasing physical activity improve their symptoms. These are good first steps. Outside of that, other lifestyle changes, dietary approaches, probiotics, and mental health therapies can be indicated. Probiotics have been found to be beneficial in IBS patients by slowing down the transit time of the colon, reducing the average number of bowel movements per day, improving stool consistency, overall symptoms, and overall the quality of life in these patients. The low FODMAP diet is a strategy that can be useful for individuals, and it is an elimination diet done with a dietitian. The FODMAP diet is done in stages, where first stage is elimination of all FODMAP foods like fruits, vegetables, legumes, dairy, and wheat. Slowly, foods are reincorporated to test tolerance. This is a good way to identify which foods cause symptoms so an individual can avoid those foods and have more variety in their diet otherwise. This is not intended to be a long-term diet, but more a way to determine specific foods causing symptoms. In addition to dietary strategies, physicians sometimes prescribe medications to treat the symptoms of diarrhea or constipation associated with IBS. Inflammatory bowel disease, IBD, includes 2 types of disorders, ulcerative colitis and Crohn's disease. IBD is different from IBS. Ulcerative colitis is characterized by mucosal inflammation, which starts distally and can extend proximally to involve the whole colon. It is characterized by inflammation and ulceration of the colon and rectum. Abnormal reactions of the immune system cause inflammation and ulcers on the inner lining of the large intestine. Symptoms can vary, but include diarrhea, bloody stool, abdominal pain and cramping, bowel movement urgency, fatigue, nausea, vomiting, and weight loss. Complications include anemia, bone problems, colorectal cancer, perforation, and severe rectal bleeding. Although the cause of UC is unknown, genes can play a role along with abnormal reactions of the immune system, causing inflammation and ulcers on the inner lining of the large intestine. Additionally, microbiome differences in the environment can play a role. Diagnosis involves blood tests to look for complications such as anemia or infection, stool tests, scope of the large intestine to see how much is affected. Treatment includes typically medications and surgery. Doctors prescribe medicines to reduce inflammation in the large intestine and to help bring on and maintain remission. People with ulcerative colitis typically need lifelong treatment with medications unless they have surgery to remove the colon and rectum. Ulcerative colitis symptoms may cause some people to lose their appetite and eat less, and they may not get enough nutrients. Dietary-wise, research has shown FODMAP-restricted diets, the Mediterranean diet, and anti-inflammatory diets to be promising in reducing intestinal inflammation and improving UC patient outcomes. Additionally, adhering to a strict diet that includes fruits, vegetables, and whole grains while limiting red meat, processed foods, and dairy products can help reduce symptoms and improve the quality of life in patients with UC. Crohn's disease can affect any part of the digestive tract, though most commonly the small intestine and beginning of the large intestine. Symptoms include diarrhea, cramping, abdominal pain, unintentional weight loss, fever, anemia, joint pain, nausea, vomiting, and loss of appetite. Complications also include anemia, bone problems, malnutrition, intestinal obstruction, a partial or total blockage of movement in the intestines, fistulas, which are abnormal passages or tunnels between two organs or between an organ and the outside of the body, ulcers or open sores, and abscesses, painful, swollen, pus-filled pockets of infection. Although the cause of Crohn's disease is unknown, it may be due to genetics, the microbiome, and abnormal reaction of the body's immune system, which happens when the immune system attacks bacteria that tend to live in the intestines. Abnormal immune reactions can be triggered by the environment, genes, or microbiome. Diagnosis involves blood tests to look for complications such as anemia or infection, stool tests, scope to view the GI tract, so colonoscopy, endoscopy, and upper GI endoscopy. There's no single way to treat every person who has Crohn's disease. The goals of treatment are to lower inflammation and prevent flares. Medicines can reduce inflammation and bring on and maintain remission. Many people will need surgery to treat their Crohn's disease, primarily to treat complications and improve symptoms, though it does not cure it. Changes in certain types of bacteria in the digestive tract may lead to IBD, including Crohn's disease. Postbiotics can potentially enhance intestinal epithelial bacteria barrier integrity, reduce intestinal permeability, and modulate immune responses through anti-inflammatory mechanisms. Crohn's disease exclusion diet, CDED, combined with partial enteral nutrition has shown superior tolerability and comparable efficacy with sustained remission accompanied by favorable microbiome remodeling in randomized controlled trials. This is a structured dietary approach that combines whole foods with partial enteral nutrition, typically using a specific formula. AGA recommends considering this diet in patients who cannot tolerate enteral nutrition or who have not responded adequately to biologic therapy. This diet aims to promote mucosal healing by restoring barrier integrity and reducing inflammation. Parenteral nutrition is a way of delivering essential nutrients like carbohydrates as dextrose, proteins as amino acids, and fats directly into the bloodstream through a central or peripheral vein. While enteral nutrition is always preferred when possible, parenteral nutrition becomes necessary when patients cannot meet their nutritional needs by mouth or through the gut for 7 to 10 days. Micronutrient deficiencies are common in patients with Crohn's disease, with iron, vitamin B12, vitamin D, folic acid, selenium, and zinc being the most frequently affected. These deficiencies may lead to significant comorbidities, including osteoporosis, anemia, carcinogenesis, poor wound healing, and chronic inflammation. The Mediterranean diet has been found to be beneficial in reducing inflammation and enhancing the quality of life in patients. The Mediterranean diet is preferred over other dietary approaches due to its broad health benefits and high adherence rates. Next up are adverse food reactions that are defined as any abnormal reaction following the ingestion of food. The different adverse reactions include food hypersensitivity, such as food intolerance and food allergy. A food intolerance is non-immunological response initiated by a food or food component at a dose normally tolerated and accounts for most adverse food responses. Food intolerances can include wheat, histamine, food additives, lactose, and more. Symptoms can range from dermatological symptoms to GI symptoms like stomach cramps, diarrhea, gas, and nausea. Typically, the clinical manifestation of an intolerance to a food will occur immediately after consumption, or sometimes it may take up to 48 hours. Lactose intolerance is a common intolerance where individuals do not produce enough of the enzyme lactase. The undigested lactose moves into the large intestine, where it draws in water, causing diarrhea. The bacteria metabolize the lactose, leading to gas and bloating. Typically, symptoms arise within 30 minutes to 2 hours of ingestion. The severity of symptoms will vary based on how much of the food was consumed. For some individuals with lactose intolerance, they could tolerate hard cheeses and yogurt, but not necessarily a full glass of cow's milk. Most humans are born with the ability to digest lactose, as human milk does contain lactose, but this depends on genetics. It's common for lactase production to decline over time in primary lactase deficiency. Secondary lactase deficiency can occur from damage to the intestine with celiac disease or IBD. Typically, this is temporary. Food allergy is an abnormal immune response to a food protein mediated by immunoglobulin E, IgE, and non-IgE or mixed IgE, non-IgE immunological mechanisms. Food allergic reactions vary in severity from mild symptoms, including hives and lip swelling, to severe life-threatening symptoms, often called anaphylaxis, that may involve fatal respiratory problems and shock. Most symptoms will occur within 2 hours of ingestion. However, they can also be within minutes. While promising prevention and therapeutic strategies are being developed, food allergies currently cannot be cured. The top 9 allergens are milk, eggs, fish, shellfish, tree nuts, peanuts, wheat, soybeans, and sesame. Risk for allergies include eczema, genes, and changes to the microbiome. The skin disease called eczema is the biggest risk factor for developing food allergies. Children with moderate to severe eczema have greater risk for food allergies than children with mild or no eczema. Scientists think the immune system may perceive food allergens absorbed by the skin as invaders, and this can lead to a food allergy. Many researchers think environmental changes during the past few decades may be altering our microbiome, that is, the community of bacteria, fungi, and other microscopic organisms that naturally live in and on our bodies. The environmental changes include overuse of antibiotics and hand sanitizers, a shift from rural to urban living, sterile indoor environments, and an increase in births by cesarean section or C-section. The impact of these changes on our microbiome may be affecting our immune health, including making food allergies more common. The gold standard for diagnosing food allergy is an oral food challenge. In this procedure, a food is eaten slowly in gradual increasing amounts under medical supervision to accurately diagnose or rule out a true food allergy. Although, due to time, cost, and risk, these are not always conducted. The most frequently used food allergy diagnostics are the allergy skin prick test and the allergy blood test. In a skin prick test, a lancet is used to prick the skin under a drop of allergen extract. If the person is allergic to the allergen, a raised red bump will appear at the site of the prick after about 15 minutes. An allergy blood test measures the level of a type of antibody called IgE that is specific to a particular food or protein within the food. People who have a food allergy make more IgE than normal to that food or protein. Unfortunately, the results of these tests may indicate that a person has a food allergy when they really don't, a result known as false positive. This is an issue especially for people with atopic dermatitis who are more likely to have high total IgE levels and positive skin prick or blood tests for foods, but may not necessarily have a food allergy. The presence of IgE antibodies doesn't definitively mean a person has a food allergy. It's common to have positive IgE test, but still be able to consume the food without symptoms. Lastly is celiac disease. Celiac disease is a chronic digestive and immune disorder that damages the small intestine. The disease is triggered by eating foods containing gluten. Gluten is a protein found naturally in wheat, barley, and rye, and is common in foods such as bread, pasta, cookies, and cake. Ongoing consumption of gluten damages the villi in the small intestine and negatively impacts nutrient absorption. Symptoms include bloating, chronic diarrhea, gas, constipation, nausea, vomiting, abdominal pain, and stool changes. Most people with celiac disease have one or more symptoms before they are diagnosed and begin treatment. People with celiac disease who have no symptoms can still develop complications over time if they do not get treatment. Long-term complications of celiac disease include anemia, malnutrition, reproductive issues, and osteomalacia, or bone softening. Celiac disease is hereditary. To diagnose celiac disease, a blood test will first be done to show levels of antibodies. However, this test may not be accurate if you're already following a gluten-free diet. With an intestinal biopsy, this is done during an upper GI endoscopy. Lastly, a skin biopsy can be done if you have a rash that might be dermatitis herpetiformis. The only cure for celiac disease is to eliminate gluten from the diet. After eliminating gluten from the diet, usually tissues heal within 6 months, although it can take longer. Typically, ongoing blood tests may be done to check for antibody levels, which would be higher in untreated celiac disease but return to normal after treatment. Celiac disease is different from gluten sensitivity or wheat intolerance. You may hear terminology non-celiac gluten sensitivity. If you have gluten sensitivity, you may have symptoms like those of celiac disease, such as abdominal pain and tiredness. Unlike celiac disease, gluten sensitivity does not damage the small intestine. Celiac disease is also different from a wheat allergy. In both cases, your immune system reacts to wheat. However, some symptoms of wheat allergies, such as having itchy eyes or a hard time breathing, are different from celiac disease. Wheat allergies also do not cause long-term damage to the small intestine.